Welcome to the Sports Docs Podcast. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan.
And on each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice. Are you one of the many surgeons who thinks that getting osteochondral allografts is a complex and time-consuming process? Well, you're not alone. But we're excited to tell you that there is a simpler way.
At JRF Ortho, they get it. They've heard your concerns and made it their goal to simplify the process. They're not just any company. They are leaders in fresh osteochondral allografts, holding over 60% of the global market share.
JRF Ortho is committed to accommodating your needs, delivering allografts usually around 30 days, and it's all on your terms. You choose your scheduling option, whether it's specifying a surgical date, providing a date range, or just requesting the earliest available allograft. Your preferences are their top priority.
And there's more. They offer pre-sutured tendons and meniscus, and ordering is as easy as a few clicks on their user-friendly online ordering system.
So why make it complicated when you can make it JRF Ortho easy? Simplify your allograft procurement today. Your journey to seamless osteochondral allograft starts with JRF Ortho. To learn more, visit jrfortho.org.
On today's episode, we're focusing on Osteochondral Allograft Transplantation, or OCA, with Dr. William Bugbee. We have great articles for you that will contribute well to our conversation on OCA, including allograft preparation and storage, graft choice, surgical technique, and clinical outcomes of OCA, as well as return to sport. As always, links to all the papers that we discuss on the show today can be found on our podcast website, www.thesportsdocspod.com.
So we'll start off our discussion today with an article authored by our guest, Dr. Bill Bugbee, from the May 2022 issue of AJSM titled Fresh Osteochondral and Chondral Allograft Preservation and Storage Media, a systematic review of the literature. So long story short, there was significant variability both in experimental designs as well as incomplete reporting across the studies, so no real conclusions could be drawn about optimal storage conclusions, unfortunately. While 60% of animal models suggested that storage time may impact outcomes and 80% indicated inferior outcomes with frozen OCA compared to fresh OCA, the authors noted that 75% of clinical studies reported no correlation between storage time and outcomes. So we have a lot left to learn here.
Then, from the March 2022 issue of AJSM, we review an article titled Association of Sex Mismatch Between Donor and Recipient with Graft Survivorship at 5 Years After OCA Transplantation. Dr. Gamal and his colleagues at Brigham and Women's reported that a significantly lower rate of graft survival was observed after different sex donor recipient transplant compared to same-sex donor recipient OCA, and that's 63% compared to 92%. Patients who received a donor recipient sex mismatch were 2.9 times more likely to fail. Male donor to female recipient demonstrated the highest likelihood of failure compared to all other combinations.
We're joined today by Dr. William Bugbee, a board-certified orthopedic surgeon specializing in joint reconstruction and cartilage restoration at the Scripps Clinic in La Jolla, California. Dr. Bugbee received his medical degree from UC San Diego and remained at UC San Diego for his orthopedic surgery residency. He then went on to complete a fellowship in joint reconstruction at the Anderson Orthopedic Research Institute. Dr. Bugbee has published extensively on the topic of osteochondral allograft transplantation. Two of his articles we review in this podcast episode are authored by him. So we're very excited that he'll be joining us today to share his expertise with all of you. So without further ado, welcome to the show, Dr. Bugbee. So welcome to the show, Bill. Thank you so much for taking the time to join us tonight and share your expertise with our listeners.
It's a privilege and a pleasure to be here. Looking forward to it.
Yeah, thank you so much.
So before we dive into all the fun stuff like surgical technique and clinical outcomes of osteochondral allograft transplant, we wanted to talk a little bit first about graft preparation and storage. So for our listeners, starting with graft prep, can you walk us through the process of an osteochondral allograft preparation as you know it?
So I guess to understand the question, when you say preparation, you talking about from recovery to all that, or from in the OR, or what's the whole story, the legacy and all that?
Yeah, so good question. I would say, so you wrote that paper that talked about graft storage and like harvest conditions and whether or not that would impact outcomes. So I guess for our listeners, like our physical therapists that are listening that aren't in the OR, haven't seen an osteochondral allograft, like how does it go from, I guess, the donor to in the hands of the surgeon?
Sure. I think the first most important thing to realize that this is a gift from someone who's family of someone who's deceased. So you have to honor that gift and understand when it's in the OR, it's not just a widget or a device made by an orthopedic manufacturer. It's a human tissue, and you honor that and that gift that people made. That said, for every happiness when we do a procedure on somebody, there's a sadness on the backside. And so I could give you a million stories about donor families wanting to know, that their child who passed did something good for other people. So it's pretty heartwarming, and I almost cry about it when I hear it. But the other important thing is to understand that this technology, I guess you have to call it that, even though it's donor tissue, has evolved. When we first started doing this, it was put the tissue in as soon as possible because it didn't have a shelf life, and evolved to the point now where we created systems where the shelf life could last. We like to use 28 days. That's semi-arbitrary, some science behind that. Others are trying to extend that, but I would prefer it to go into the recipient as soon as possible. So recovery and processing of the tissue happens in a tissue bank that's specialized to do this. Once that's done, all the testing takes place, and that takes most of the serology takes place in a few days, but the bacterial test to make sure it's not contaminated takes up to 14 days, and that's where a lot of the delay occurs. Also occurs in clearing the donor to know that that they didn't have any health issues that would impact the graft. At that point, you get 14 days to put it in. The surgeon calls the tissue bank, and the tissue bank says, we have a donor that works for what you need. Deliverable in a cold storage that can stay for a week or so in ice bath and in tissue culture media. And that's been the breakthrough, is to have a media that can maintain chondrocyte viability for an extended period. The analogy I would give most people is, think about the milk in your fridge. It says the born on date, and you want to drink it as fresh as possible, but if it's a month out and it says it's past the expiration or nearing it, you're going to check it first. But so that's the analogy, because it's a living tissue. So once it gets to the OR, you can't tell if it's quality or not. So you have to rely on the people that took care of it and the science behind the processing. And that's why choosing a tissue bank or someone that's providing the tissue that's reputable and knows what they're doing is important. So I think that's the main background about getting a graft and knowing that it's quality, the highest quality it could be, but it's still variable.
Yeah, absolutely. I think there's also still a lot of myth around the ability to get grafts, whereas even a decade ago, it was sort of, okay, if you're in certain parts of the country, you're at certain centers, otherwise you might be waiting 3 months, 6 months, these really long wait times. And the whole process has gotten a lot smoother. Since you've been doing this for a good amount of time, can you speak to, how those improvements came about, as well as, what you've seen change?
Yeah, I guess I would say, of all the things I've done in my life, I'm most proud of being able to make it happen for other people. Because when I started out I saw my first allograft in 1986, believe it or not. And I was mesmerized by the quality. And I was fortunate enough to be in San Diego, where it was one of the 3 places in North America that could do it, because we had our own tissue bank. We had a burn center, transplant, and all that. So the logistics were there. First thing we started in the lab was trying to figure out how to extend this, because we were doing 15 or 20 a year. I knew people weren't getting that treatment. There wasn't much going on. So developing a storage media using all the stuff that we learned from other people, and then studying it and making sure that we could do all this, has been very, very rewarding in a way. And in the end, now, when I was starting, I was the king of the castle, right? And now I'm happy to hear everyone's doing it. You guys are doing it. Everyone's doing it. And I think that's great. And I'm very happy with that, because from, 30 of these cases a year in the US. Now there's, thousands, and it's just limited by the amount of tissue, which is really your question. Nowadays, you can almost schedule a surgery if it's a femoral condyle or something simple, because the tissue bank knows their process, knows what they have available. And I didn't realize that was important, except for people that work in a surgery center. I just added my cases on at the end of the day, 10 o'clock at night, 8 o'clock at night. You can't do that in a surgery center, and it's inconvenient. But if you wanted to do this surgery and you hadn't done it before, or hadn't done very many, you could say, look, I have a window on my patient. Can I do it on a Friday, next month? And the tissue bank will say, okay, we have an 80% chance of being able to deliver a medial femoral condyle to you. And that's been a revolution for convenience. And before, I used to get patients referred to me, I can't get a graft. I've been waiting 6 months. Will you take care of this patient? But that's changed, I believe. It's still difficult to get some of the specialty grafts, like on a femoral head, a humeral head, patella, trope. Those are easier to get now, but it's still not as easy as just getting a standard graft. And then, of course, you have little plugs now. You can get those off the shelf. So that's been the revolution, to mainstream it, to make it a pretty standard surgical part of your armamentarium. It's not so esoteric.
So something I work, and I think Catherine does as well too, primarily out of a surgery center. And the question that they always ask me is like storage. We talked a little bit about shelf life, but storage conditions. So, can you talk a little bit about the different types of storage temperatures? There's that cold, and then there's an increasing push towards like room temperature or viability temperature storage, or I guess physiologic temperature. Can you talk a little bit more about that and how it impacts graft or chondrocyte viability?
So the first thing is the milk analogy. You want your milk stored at room temperature, because you can't pasteurize grafts, so you can't sterilize them. So I would, the reason that we cold store it is it puts everything to sleep, but it also stops overgrowth of fungus and bacteria. And that's safety is still the number one concern. And there's the safety record of allografts has been quite incredible, except for one event. So people are always trying to move the bar forward. And of course, if you look at cell biology, physiologic storage is healthier for the cells. But and then there's the idea if you cold and warm it up. But that's never been shown to me in any study that makes it better or longer. The longer you warm store things, the more chance you get bacterial overgrowth, and people have been unsuccessful. The thing that's sort of ironic is we're adding nutrients and other factors to the media to try to prolong the storage, but of course we're putting them to sleep. So the chondrocytes are very quiescent anyway. And so does that matter? It seems to, but they need a little bit of nutrition. So I don't think, there's a few breakthroughs here and there to stop the cell death mechanism that happens. And I'll tell you a really interesting factoid that most people don't know is if you can take a piece of cartilage with viable chondrocytes, drop it in a culture media, and the chondrocytes will stay alive indefinitely in the lab. As soon as you put that with a piece of bone, they start dying. So therein lies the rub. How do you fix that? And so innovations in stabilizing the apoptosis pathway, blocking inhibitors. We're looking at lipids are the bad actor in bone, and lipids are very toxic, believe it or not. And if you look into, so we think that's where you can prolong the storage and keep it cold and have less cell death. If you look at, again, I keep making the analogy to food industry. Lipids have been studied. They're the bad actor. They make everything go bad, right? And so using some of the stuff we've learned from the food industry to apply them to storage of grafts. But I personally would be very careful about using a graft that's been stored in room temperature, because I don't want to have a weird bacteria get in my patient. It's been too safe and too successful to try to inch the bar forward with something that adds risk.
It's like the risk doesn't outweigh the benefit, at least based on the current literature. So that makes sense.
Yeah,
Thank you.
Exactly. Long answer, but that's the bottom line.
No, that's a good answer.
Well, I also think, Bill, with your background in arthroplasty, you must be very sensitive to you can see when bad things have happened in the arthroplasty world where there is a recall or there is, some sort of,
Yeah.
the metal on metal, all these types of things. It's just catastrophic. So, it's so important to sort of maintain the cartilage in a way that we don't, end up in that sort of catastrophic space.
Yeah, and you're relying, that's why I pointed about know where you get the graft from. It's not a widget that's been made, sterilized, and put in a package. You got to know, and the safety is the people that are recovering the donor, testing the donor, knowing everything and handling it properly. And the major event in 1999 was because of poor handling, and the tissue bank in question didn't even follow their own protocols. So the safety record is remarkable. And who would mess with that? Because we're dealing with non-fatal disease. You'd hate to do something really bad. And so we've, knock on wood, never had a case of disease transmission in 30 plus years.
We touched on it briefly as far as, how long you will store the graft. I believe, did you say 28 days is sort of your kind of ballpark?
Yeah.
And in your paper, you talked about that on more unsuccessful outcomes after 28 days. And then, Dr. Gamal had also published a paper about late transplant groups, and they had a lower rate of graft survival. Is there any sort of window that you sort of say, you know what, I'm going to make an exception here, and this is why, or it's just really stay to that sort of end point and don't budge that?
Yeah, the 28 days we had to establish because in the tissue banking, you have to make a standard operating protocol. You can't deviate. So we used our data to suggest it wasn't, that things got bad at 28 days. We just saw the decline, and we looked at how long it took to get the graft out, and that gave us 14 days for the logistics of getting it out to people. Would 35 days be okay? I don't know. There's other researchers that have suggested 70% viability is a cutoff, and that's based on some not very robust data. So this is the big unknown, like what would be best, and no one knows for sure. And even if you take a whole group of 28-day grafts, some of them are probably have more viability than others. We know that it's highly variable, and that's again back to the case. This is human tissue, and every human's different. It's not a widget. So in the end, yes, we would like to extend it out so we don't lose as many grafts from expiration per se, but we want to do it in a safe manner. The other thing you got to know is different tissue banks will use a longer protocol because getting the donor cleared and getting all the data that they need to clear the actual donor takes them weeks and weeks. So 28 days wouldn't work for them, and they would be out of the business. So it's a wild west a little bit, but the people that are supplying grafts are doing it in a conscientious manner. But validating all the variables is hard to do because, as you well know, when you operate on someone, there's so many variables. It's not. I did a study thinking the same thing. Late grafts, 28-day grafts would function worse than the 7-day grafts I used to put in, but it was the opposite. And it was the opposite because during that whole period from back in the 90s when I had the grafts in 3 to 7 days to now, I got better at surgery. I got better at choosing patients. I got better at all the protocols. I got better at everything else. And even though you tried to correct for that stuff, size of graft, everything else, everything advances. So picking out one variable to make a difference is hard to do. And that's papers that we looked at, same thing. It's really tough. So awesome. Just want more people to get the right, get a donor, a tissue that they need in a safe manner. But I don't know the answer, but stay tuned. We'll figure it out.
Well, that segues really nicely into our next. You were talking about all those different variables to consider, and one of those variables is proper graft selection. So we want to talk a little bit about how you select an appropriate graft, and a lot of the emphasis is on size matching. We'll talk a little bit about some of the other variables, but what imaging are you using to determine that a graft is acceptable for your patient? Is it radiographs or is it something more involved?
A plain X-ray. And just a simple X-ray. That's where we started with. We used to put a size marker next to it and correct the size and try to match within a couple millimeters. I have a slightly different setup because I do all that myself. But if you're out there, you send an MRI to the tissue bank. JRF Ortho will measure it for you, and they'll pick a donor based on condylar width or condylar length and all that. But much like Alan Gross, who does some of the bigger tibial plateaus, I've come down to just give me a large, medium to large male donor, and I'll be happy for anybody. And the problem is never that the grafts are too big unless you're in specialty areas like the tibial plateau or the ankle, a whole ankle. The problem is getting a small one. And you all know notch width, and you have the hardest part is a medial femoral condyle, and the donor's wide and the recipient, the donor's narrow and the recipient is wide, and your radius of curvature isn't right, and you got to get a 25 millimeter graft out of it. And that's really important in osteochondritis dissecans, where the condyles are flat in the recipient, and the donor may have the same measurement, but has a different geometry. So bigger tends to always be better in femoral condyles and trochleas because you can find the right shape.
That actually sort of brings up a side question that you just talking about dissecans. So your training was in arthroplasty, but obviously this problem can also be in the adolescent. What does your practice look like now as far as age range and what's coming into the doors?
Yeah, we spoke briefly about that before. I'm a fellowship trained arthroplasty surgeon that just happened to be at UCSD when cartilage repair became a thing as a resident. Then I came back to run the arthroplasty program, but with the idea that I was going to take over our allograft program. This would have been in 97, 95, 96, 97. And it was always the funnest part of my practice. We don't digress into arthroplasty, but that's the ultimate widget makers. I mean, we're trying to split the atom in total hip replacement. It's so good that it's not that interesting to try to make a different widget to do the same thing. But in cartilage repair, there's all sorts of cool stuff to learn, and we're not very good at it. My goal in life would be to be as good in cartilage repair as I am in hip arthroplasty with 98% happiness.
Right.
I guess my practice, I would say, is about 25% joint preservation and 75% joint replacement. Mm-hmm. In the hip, there's not that much joint preservation unless you're an arthroscopist, hip arthroscopist, you can call it. But in the knee, there's all this gray area, the unsolved problem of the 30 to 50-year-old early arthritic patient, which is the biggest challenge for sports docs and for arthroplasty surgeons. But if I was to choose, the perfect patient for me that I'd love to see day in and day out, it's the adolescent with OCD, because I can hit a home run with that every single day. So I see 13-year-olds with weird problems, weird osteonecrosis type things, and I see teenagers that have osteochondritis dissecans that didn't get fixed, and then I see the middle-aged people, and it's kind of fun. And it used to be just fix the hole, and now it's a whole bunch of other stuff you have to do. And
it's great.
Yeah. So you mentioned something, your ideal graft is a medium to large medial femoral condyle. So I feel like a lot of people feel that. So because of that, there's a lot of limitation on medial femoral condyles that are out there. And I think if you're waiting for that perfect match, you may have to wait a little bit, not as much nowadays because of availability, but you're still waiting. So let's talk about non-orthotopic grafts. So using a lateral femoral condyle for a medial lesion. What are your thoughts on this? Do you do this often? Are there any parameters you use to make sure it'll fit?
Yeah, I think using a lateral for a medial is a good idea. Again, a big lateral has a lot of contour. And if you know your anatomy right, a lateral femoral condyle is way wider than a medial, actually. So if you need a 30 millimeter graft, you're more likely to get it out of a lateral femoral condyle than a medial. So I'll do that quite a bit if I need to. But you gotta know your stuff. It's a contralateral, so it's the opposite. So if you're in a bind and you got a big old medial femoral condyle, I'd take a big lateral and do the job. I think the trochlea too, people are trying to measure like all these parameters, but a big trochlea, you can find the right curvature. And where our studies and others have showed that if the graft you need is 20 millimeters or smaller, you can pretty much get a contour that fits from anywhere. Okay, you wouldn't know. We've done lateral to medial, we've done everything. So choosing a non-orthotopic, I would I put medial femoral condyles in the patella in a pinch, but I wouldn't do it for the trochlea. I wouldn't do it for the patella. I would do it for either medial lateral femoral condyle, and it's more the size of the lesion you're treating as much as anything. So, and as to your point, yes, you can get a lateral femoral condyle a lot easier than a medial. And oh, by the way, that cartilage is thicker too. So he asked me, is cartilage thickness non-orthotopic? It's not just the surface contour, it's thickness. So I think the thicker the cartilage, the better. And who cares what the offset is in the subcondylar plate? I don't think that's been shown to matter yet.
Yeah, agree. So another paper that we had sent over to discuss today, excuse me, it was about sex mismatch. So between donor and recipient on an OCA graft. So Dr. Kamal had, he was another one. So he was at the Brigham when we were both there. He's now at HSS, but we did have some time to train under him, which was very nice. So he reported that sex mismatch did have a negative effect on OCA survival, particularly if it was male going into a female. So, what has been your experience with this, and do you have any sort of differing opinions?
Yeah, we did the same study, and we actually were going to pool our data, but we haven't gotten around to do with it, and we found a different outcome. Okay. We found that sex didn't matter, and a couple of things. We don't want to digress into statistics, but if you look at in Dr. Gamal's paper, he made the caveat that subgroup analysis was not powered appropriately, so it was random. And that's the trouble with these studies. You're trying to correct for so many variables. We did a big study on clinical outcome, but on donor characteristics as well, and sex didn't come out of it at all, and not even the age of the donor, actually. It was really hard. I think BMI might have been the only thing. So what happens, the reason that I don't think that's as important is back to the last question. I think you have hard to match a female donor to a male size-wise. It just doesn't work. But putting a male and a female, I was surprised that he thought that didn't work. But I surmise that there's some subtle things the female population, as they get older, run into all the early arthritis things, the hormonal things that make a 35-year-old woman a challenging cartilage patient because of all the life changes and everything else. I think that you guys would probably know more than me in women's health. Those things matter. So I think there's a sensitivity for the female recipient that we haven't been able to get a handle on. So I think I would take whatever graft I could, but I just don't see, because I just asked for a big male donor, that's what I get. And when you get a female condyle that's tiny, you just can't do much with it. That said, those are now becoming cores. Mm-hmm. And so there's a lot of cores on the shelf that may be from female donors. And I don't know if Andreas was doing cores back then when he did the study. So I think there's other variables in the immunological spectrum. I think there's blood type mismatch, and I think there's HLA mismatch and all the other stuff that gets involved in there. So I think that I wouldn't make a big deal out of the sex mismatch, because practically you probably aren't going to use too many. And there's 3/4 of the donors are males anyway. Right. So
I think those are all good points. And sometimes, we see a headline and you kind of go to that, and there's a lot behind it.
But it's nice to not have to add in yet another variable, if we're looking at trying to match contour and size. And now I get a perfect graft and I look and I go, oh gosh, no, it's a sex mismatch. I have to turn that down, and then the patient has to wait even longer. So it's actually relieving to see that your data did not show that. I think it opens up more possibilities.
We still have a positive donor. So if you start making criteria, you'll never get a donor. And heck, I just want to take care of the patient, and I could have a suboptimal donor or a perfect donor, and I screw up the surgery, or there's all the things. So just use the tissue as best you can.
Absolutely.
Thank you for listening to this episode of the Sports Docs. We hope you enjoyed the first part of our discussion as much as we did. On the next episode, we'll continue our conversation with Dr. Bill Bugbee and shift our focus to surgical technique and clinical outcomes. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and now on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod and Twitter at thesports.pod. We love your feedback.